Be alright.
Ta-da.
In the UK, some 5 million major operations are carried out every year.
It'll be absolutely fine. We'll take really good care of him.
But some patients' procedures are so complex, only the most skilled surgeons can perform them.
Right, can I start?
Table is locked, we're good.
Nice, please.
Millimetres count. Your focus has to be perfect.
University Hospital Southampton pioneers techniques to treat conditions that few others dare to take on.
This is the sort of operation that you lose sleep over.
So that's the squeaky bum time.
You're always trying to push the boundaries of what's possible.
Every step needs to be done meticulously.
But being at the cutting edge of modern medicine comes with great risk.
This is the tricky bit. Right, let's just get this right.
Sometimes we're a whisker away from failure.
The surgeons bear the ultimate responsibility.
Just worried it's going to crack the bone.
Sometimes it's surgery and things can change just like that.
You are very close to the things you don't want to cut.
If it were to bleed, its entire blood volume within a matter of minutes would bleed out.
Okay, everyone away. Shocking.
I have quite a number of cases that I have never, ever forgotten when something doesn't go well. And that stays with you forever.
It's just not right.
This is what really happens behind the closed doors of their operating theatres.
We've got the lump out.
Excellent work.
You can't really ever let your guard down.
Operation's all done.
It really is the difference between a patient making it through or not.
University Hospital Southampton is one of the country's leading specialist centres for cancer treatment. Its surgeons perform more than 8,000 cancer surgeries every year, where an operation is often the only option to try to save their patient's life. Maxillofacial consultant Sanjay Sharma is one of the consultants who takes on some of the most complex operations, removing cancers from the head, neck and face.
It's a very emotional place to operate on. It is at the forefront of people's appearance. On the flip side, that does make it very rewarding when it all goes right.
Ever since they trained together, Sanjay has worked closely with fellow maxillofacial surgeon Madan Etunandan.
I spend more time with Sanjay than even with my family. Trust is a very big part of these operations because they are complicated.
Their next case is particularly challenging, removing a 76-year-old man's right eye to cut out the cancer growing deep behind it that would otherwise kill him.
The shock of losing an eye is big. I fully understand it is an incredibly difficult decision for patients to make.
It's hoped the operation will leave their patient cancer-free, but it's a stark choice. An eye for a life. "76-year-old retired lorry driver Mick lives just outside Chichester in West Sussex, close to his sister.
I normally go to Carol if I've got a problem. I'll pop in, have a cup of tea and a chat.
8 years ago, Mick had a kidney transplant. The anti-rejection medication he takes made him vulnerable to sunlight, and he developed skin cancer on his face.
When they say you've got cancer, you go, oh, good God, have I really? Will I die? Who's making the tea? I would, but I don't know where anything is.
Ah, yeah, that's what you usually
Be
say.
probably quicker if you make it.
It might be.
Right.
Right, okay.
After finding a lump above his right eye, Mick had surgery to remove skin and part of his eyebrow.
It is difficult watching his health deteriorate like this. He's been suffering a lot of discomfort.
But now the cancer has come back, infiltrating his right eyeball, plus the tissue and bone of the eye socket.
It's just unlucky. You know, some people get far worse diseases than me.
Now the only option surgeons have is to cut the tumour out, remove his right eye, and then rebuild his face.
How are you feeling?
All right, why?
Well, you know.
Don't bother me.
I think he's very worried about the operation, but he won't admit it. But then maybe he doesn't want me to worry about it. But I am.
Losing an eye has a small price to pay for the rest of me still working. It's not the nicest things, but what would you do?
It's quite an aggressive cancer because this is the third time it has come back.
Sanjay and Etu's plan to cure Mick of cancer requires 2 teams of surgeons to carry out a series of high-risk procedures on his head and neck.
It's invading all the way back into his eye socket and upwards through the bone.
The cancer is not just in the eyeball, but also the bone above it. If left alone, it would kill Mick within a year, so surgery is his only chance of a cure. After opening Mick's right eye cavity, surgeons must release the nerves, muscles and vessels inside it without puncturing the thin roof of the socket, which could injure his brain. Then they can remove the eye, the tumour and the contents of the socket. Next, a section of Mick's skull above his eye will be cut out, exposing the dura, the membrane that surrounds the brain, which is thin and can be easily damaged. Finally, a section of cancer in the bony roof of the eye socket can be taken out. At the same time, surgeons will harvest a flap of skin and tissue with blood vessels attached from Mick's left thigh. The flap will be divided in 2 before its vessels are connected to an artery and vein in his neck to keep it alive. One section will fill Mick's eye socket cavity, the other will be stitched on top to form his new face.
It's going to be a big sort of balancing act.
That's because Mick is at greater risk of bleeding during the operation because he's on blood-thinning medication for a clot.
If he does have any bleeding, it can go straight into the cranial cavity where the brain is because it's the easiest place for the bleeding to extend into and then have serious consequences, stroke or death.
This operation has got to work to end all this aggravation I've had with it. And I hope they go in deep enough to get rid of all of it. I've got here. Yeah, everything's all right. Phone you later when I know more. Right, bye.
Early morning, and across the hospital's 41 theatres, dozens of operations are starting from heart to neurosurgery. In Theatre 13, a 14-strong team is preparing for Mick's operation, led by Sanjay and Etu.
So we have Michael, who's 76, so he's got a recurrent SCC in his right eyebrow frontal bone orbit.
Mick's procedure is rare, one of just 10 carried out every year in the UK. It is so complex the surgeons will work in 2 teams. Sanjay and plastic surgeon Nigel Horlock will harvest tissue from Mick's thigh, while Etu will work on Mick's head with maxillofacial surgeon Srini Hassan.
We are a very, very close team and we enjoy what we are doing, but we are very aware of the magnitude of the procedure.
Thank you.
Gonna have a last look out my right eye. Make use of it while I can.
Hiya, Michael.
Hello.
Hi, I'm Jackie. I'll be taking
How are you?
Good, you?
Are we going now?
We are.
Oh, we're going.
We're off.
All right. At last. If the operation goes well, I can't see any problem. See you later. Take care. Bye.
Do you work? What was your job?
I was a lorry driver.
Oh, so?
But it's like everything else. There's always a bit of a risk. Here we go.
Yeah.
Hello, sir. We're all ready for you. That's perfect. Just lie back there for me.
Then we will slowly get you off to sleep.
Just don't get the knives and all that out while I can see them.
All right?
A day ago, Mick was temporarily taken off his blood-thinning medication. Otherwise, his blood won't clot during surgery, and he could bleed out.
You just take some nice, slow, deep breaths.
But the drug could stay in his system for up to 48 hours, so excessive bleeding is still a risk.
Let's do some marking. You want to do the marking first? Yeah.
You good? Just kick off.
Yeah, so.
Sanjay makes an incision in Mick's left thigh. Then he and Nigel will cut the 10 by 20 centimetre flap needed to rebuild Mick's face.
Blade, please.
At the other end of the table, Etu and Srini begin the process of removing Mick's right eye and the tumour that's grown into it and the surrounding bone.
There's quite extensive perineural infiltration.
Etu cuts a large margin around Mick's eye to ensure he removes all the tumour.
Have a brain retractor, please.
As Etu exposes Mick's nasal bone, he spots a problem.
It's a bit oozy here. Oozier than normal.
There's blood around his eye.
It's a irritating ooze. And normally we would like it to be completely bone dry when we do this.
The tumour has been compressing veins in Mick's eye socket, trapping blood that is now seeping out.
The oozing means that the blood is still quite thin. And this does increase the risk of Mick having problems. And if blood was to collect in and around the head and the brain, it can give rise to stroke or, in the worst case scenario, death.
Mixed up, please.
Mick's case is one of many complex high-risk operations at Southampton, which can only be attempted by teams of surgeons working closely together. Taking on one such case is urology surgeon Vicky Dawson, in her first year as a consultant.
It's very satisfying being able to do something to fix people. As a 14-year-old, that's what I remember driving the desire to go into medicine.
Vicky works closely with her mentor, consultant Julian Smith.
He's taught me everything I know about urology. All the skills that I have, he taught me.
Vicky's next case is so challenging, her and Julian will be operating together.
We recognised her talent early doors. Surgically, she's been great. She's relaxed. And when you're at work, you want to have fun as well as do difficult things.
Their 83-year-old patient has already had radiotherapy for prostate cancer, but now has life-threatening bladder cancer.
If someone is deemed fit enough for surgery, then you want to stop them dying of the disease that they have and improve their quality of life, ideally.
They plan to remove the patient's cancerous bladder and prostate.
So his bladder is here, and it's a bit of a small walnut. His bladder looks quite thickened, so he could have muscle-invasive disease, at which point that would mean if we do nothing, he's got about 18 months to live.
Retired schoolteacher Norman lives in Guernsey.
This is lovely. It's a good job it's not raining.
I know. Well, we couldn't have done this, could we?
Married for more than 20 years, he met his wife Miranda at a choral society.
The rain cloud hasn't shifted very far, has it?
3 years ago, Norman was diagnosed with prostate cancer, which was successfully treated with radiotherapy. But he's now developed bladder cancer.
Coffee?
Yes, please. I had the urge to go to the loo every 20 minutes or so throughout the night. My record was 23 times in one night.
There have been days when I've just wondered how much longer he would be able to keep going for.
At first, the couple thought Norman's age and a heart condition would rule out surgery.
I really thought they'd say no. You can't cope with an operation that might take up to 10 hours.
I think that's big enough.
But after extensive physical tests, Norman was declared fit for surgery.
Ah, your new slippers. When we were told no, you should have the operation, I felt it was the most enormous relief.
If I didn't have this surgery, it would shorten my life, and the painful ending it would be too. Let's go. I'm hoping to have another decent 20 years with Miranda for a start.
To try and eliminate Norman's cancer, the surgeons planned to remove both his bladder and prostate.
He is 83, so he might not cope with such a more complex, long operation. So I think it's going to be challenging on the day, but it's certainly doable.
Vicky and Julian will first cut through Norman's abdominal muscles to expose his bladder. Then they need to free it from the pubis bone and abdominal walls. Next, they must separate Norman's prostate from his rectum, which could be welded together by his previous radiotherapy, and they could easily tear the rectum. Only when the prostate is free can it be removed along with the bladder as one specimen. With the bladder gone, the surgeons will reconstruct how urine leaves Norman's body by attaching the pipes from the kidneys to a section of bowel they cut out to create a stoma. Norman's previous radiotherapy means his tissue is welded and tough, so it will be hard to dissect.
So that's prostate outlined there, and that's rectal wall there, so they're fused together.
He knows that he's at much higher risk of rectal injury because of the radiotherapy. He knows that there's potential need for a colostomy because of that.
If his rectum was torn and damaged, solid waste could no longer pass through it, and the surgeons would need to give Norman a second stoma.
If we go the wrong way and he ends up with a stoma bag for his stool, he's not going to thank us for that.
No, no.
And it's not the only challenge. Norman has surgical mesh in his abdomen from a hernia repair, which could also make access difficult.
That is going to be unpleasant, isn't it?
Yeah, it's just welded.
Norman's case is at the riskier end of surgery.
It's up there with one of the most difficult ones I've done. There are just more reasons why things might not go to plan.
Okay, kid. Take care. I'll be a new man.
I don't really want a new one.
Never mind.
I'll have the old one back.
Ta-da.
In Theatre F, a team of 11 are preparing for Norman's surgery.
Got one patient on the list. He is 83. He has got bladder cancer.
My name is Anka. I'm one of the nurses in theatre. Shall we go?
Yes, lead the way. I know what the risks are. I may not wake up. And I trust in the great spirit of the universe that I'll continue with life for a few more years.
Hello. Welcome. Oh, come on, we're friendly, really.
Lovely slippers.
Yes,
The first time they've been worn.
Exactly.
My wife bought them for me.
Especially for this occasion.
But yes.
For consultant anaesthetist Carolyn Way, this isn't a straightforward operation.
So just think of something you'd rather be dreaming about than being here. We worry more about older patients because their bodies have aged, their arteries will have aged, their hearts will have aged. Good, excellent. Have a very nice sleep. Older people are always more at risk of complications under anaesthesia.
To keep Norman safe during the operation, the team start fitting a large drip into his internal jugular vein. The central line will deliver electrolytes to help control Norman's heart rhythm, because he has a condition where it can beat abnormally fast. But just as a guide wire is inserted 15 centimetres into his vein, his heart rate changes.
Tacky. I can immediately hear the heart rate has gone up a lot.
I'm going to take the wire out because I'm in.
Yeah.
The wire's out.
I'm worried because I know at 83 his circulation won't cope well with a heart rate of 130, 140. It makes me feel anxious. My heart rate is probably doing the same sort of rate at this time. Heart rate is horrible. We really need to get the heart rate controlled literally as soon as we can. We're not ready to start yet.
If Carolyn can't get Norman's heart rate under control, his life-saving operation will have to be abandoned. But there's a more immediate concern.
If this carries on, it may deteriorate into a full-blown heart attack.
Is it worth getting the crash trolley?
In case we need, yeah.
In Theatre 13,
So we're just going through the contents of the inferior orbital fissure.
a team of 4 surgeons, led by Sanjay and Etu, have begun to remove Mick's right eyeball and the tumour growing in tissue and bone around it.
Give this tackle.
But Mick's blood is thin from anticoagulants, and there's already been bleeding. Now Etu is opening the eye socket, which is full of hazards. The cavity, the orbit, is just 4 centimetres deep and contains 5 nerves and 2 blood vessels.
It is always challenging to operate inside the orbit because visibility is limited.
Can we have a mastoid swab, wet mastoid swab, please?
There is a real risk of bleeding because you have blood vessels which come through holes in the bone. If they are cut before they are clipped, then they can retract away from the eye socket through the wall. They can continue to bleed.
Sorry, Simon, getting a bit cozy there, pal.
Now Etu starts the riskiest part of the procedure, working behind the eye to scrape cancerous tissue from the roof of the orbit.
You've got to be very careful at the roof of the orbit because it's normally very thin and you could just go into the intracranial cavity if you're not careful.
The bone roof of the orbit is 1 millimetre thick and eroded by the tumour.
It's very easy if you apply inadvertent pressure that you can make a hole into the brain, which can give rise to a stroke or death.
You're just transecting the tumour now.
There's one last structure holding the main tumour and eyeball in place. The optic nerve.
What I have to do now is make the final cuts of the roots which connect the eye to the brain. The orbital contents is now free, so then I can take it out now. It is always a significant moment when we have to remove somebody's eye. We'll never get used to it. But I would hope it will be a price worth paying.
While Etu still has cancerous bone around the eye socket to remove. Down on Mick's thigh, Sanjay and Nigel are harvesting a flap of skin and tissue that will be used to rebuild Mick's face.
Blue liggies, please.
The flap they're taking must come with an artery and a vein that can be plumbed into vessels in Mick's neck.
So the vessels here are quite small, but the vessels up here are much bigger. So we can plumb the vessels up here, the big ones, into the neck.
Without an adequate blood supply, the tissue would die.
Biggie, please. It's a real sneaky one.
The flap will be cut in two. One section will fill the eye socket, the other will cover it.
Let go there.
Each piece will be supplied with blood by small vessels called perforators.
So we'll take the little ones with the big vessel coming all the way up here.
The perforator vessels are the smaller vessels which come off the main trunk vessels, and then they divide and they spread like a tree.
We need to do this now.
Just I hope that.
They must cut away more than 60 tiny vessels branching off the main artery.
It's just a bit of a tedious dissection to get all these vessels out. We need to isolate the entire blood supply from the main trunk. It's still a long way before the flap's harvested.
Pledge.
With the tumour behind Mick's eyeball now out, the team can see the erosion in the bony roof of the socket caused by the growing cancer.
So we're going to have burrow here.
To take out the orbit, they must first remove a 10-centimetre section of his frontal bone.
And one burrow here, separate the dura and connect it up.
There are now 5 surgeons in theatre.
Marker pen, come.
Neurosurgeon Nijaguna Matad, who specialises in skull-based surgery, is drilling into bone around 10 millimetres thick, just above the dura, the thin membrane protecting Mick's brain.
We have to prevent injury to the underlying lining, i.e. the dura and the brain. If you make a hole, you can get leakage of brain fluid, and that can give rise to problems of infection.
We're just supporting the craniotomy here so that it doesn't fall on the floor.
Hold on.
We managed to preserve the integrity of the dura so far. Catty, please.
The rough edge of the orbit's roof is exposed, along with a new problem.
I can see that the dura is quite thin and it's quite stuck to the roof of the eye socket.
As they start delicately peeling the dura away from the base of the skull, Shrini spots something on its surface.
There's a bit of a bulge there, Makat.
I can see that there are 2 small holes that have been created in the dura.
That's a problem. Sharp bone edge can make a hole.
It's likely the rough edge of the orbit's roof has torn the dura.
It's very important that we repair these stairs. Bugs can get into that area and can give rise to meningitis, which can potentially be fatal. Your own body.
It's been like this, I'd say, for several minutes.
In Theatre F, Norman's bladder cancer operation hasn't begun.
Doesn't look right.
Because his heart went into an abnormally fast rhythm while being anaesthetised.
So unless we can get Norman's heart rate under control, we will not be able to proceed. That's a huge responsibility because this is a cancer-curing operation for Norman.
Norman's condition is so serious, consultant anaesthetist Carolyn has called in colleague Harry Phillips to discuss giving Norman a drug that could bring his heart rate down.
6 of adenosine.
Yep.
So
He's not got asthma, does he?
no.
Adenosine can stop and restart the heart at its normal rhythm. But giving it comes with risk.
It can cause the heart to stop for a slightly prolonged period of time.
If it doesn't work, Carolyn needs to be ready with a backup plan in case Norman's heart needs to be restarted.
Do you want the defib in here as well? Should we put some pads on so that we're in a position to do whatever? Adenosine. 6 into
2 mils.
October.
Perfect.
Ready?
From over 130, Norman's heart rate plunges.
The adenosine stops it beating for seconds. That's 50, that's gone back. I feel deep joy knowing that we are back to where we started, which means that we can carry on with this, because this is a big day for Norman, and we all want to make it happen for him.
Hello, Doctor.
Hello. Just had a little run at 130 odd. He had some adenosine and he went back, but it was suboptimal.
They were slightly on edge that he's had a little cardiac episode. All right, thank you.
Nearly an hour and 45 minutes after Norman arrived in theatre,
Happy? Yeah.
his cancer-curing surgery can finally start.
We won't want a super long operation because we don't want him to become unstable anaesthetically. So I guess the stakes have gone up. Try and run your finger up there.
But having made an incision in the skin and rectus muscle, they're already struggling.
It's pretty stuck here.
They can't get through to the bladder.
Nice and stuck.
They're coming up against the yellow surgical mesh used to reinforce Norman's hernia repair.
Heavy scissors?
Yeah, heavy scissors, please. Thank you.
Oh, listen to that mesh.
It's quite difficult to cut because it feels so solid and it's quite brutal.
This mesh is properly tough. Like a very tight woven plastic chicken wire.
But it's only when they finally get to the tip of the bladder that they can see how much of a problem the mesh is.
The mesh is more extensive than we first thought.
Nice. Stop there.
This mesh has completely welded the bladder to the mesh itself.
Touch me there.
As they try to cut away the mesh,
forceps,
they mustn't pierce the bladder.
Suction.
If we go into the bladder, urine will spill, cancer cells will spill. That will spread cancer around the abdominal cavity and he won't be cured. So you can stay on that bone and see what we can develop over there.
Should we do... Are we going right side first?
Let's see if you can develop it.
OK, small swab, please.
You're blimey. It's pretty stuck.
Totally obliterated by the mesh.
Yeah.
The mesh covers the entire pelvis in front of the bladder, and that is going to make removing the bladder really quite tricky.
Diathermy, please.
With access blocked, Vicky and Julian have to give up their standard approach for removing the bladder.
OK.
Hopefully not a problem.
We're just gonna...
Just a challenge.
We only have one alternative, and that is to open the abdominal cavity, which holds all of the bowel and other organs, and approach the bladder that way.
Vicky starts by locating the membrane that separates the bladder from the abdominal cavity.
Oh, here it is. I wonder whether or not we should just take it a bit higher, though.
Yeah, trace up there a bit.
Diathermy, please.
She must cut through the peritoneum that surrounds the bowel.
2 Roberts, please.
Now with the peritoneum open, they can approach the bladder from a new angle.
Move this a bit.
But exposing the small bowel raises the risk it will take longer to recover from surgery. And the new approach will keep Norman on the table for longer.
Do you want to get a big swab, see if we can advance this side quite firm? I think it's going to be slow going and hard work. for every centimetre of this operation. 335s, please. Going to be a long operation, and with him having his cardiac issue at the start, we're going to have to keep an eye on things as we go.
Swab on a stick.
Central to keeping Norman stable in theatre is the anaesthetic machine. Maintaining this and other life-saving equipment
These two are in date.
is the job of clinical engineer Stephen Ball, who works fixing and servicing equipment in the hospital's basement.
This is one of the anaesthetic machines that's used in theatres, and once a year we're responsible for doing an annual maintenance check on them all.
Stephen's one of 24 engineers on the team.
It's one of those departments that people forget about until something breaks, and then we get called.
There are 30,000 pieces of medical equipment in the hospital, worth millions of pounds.
Yesterday I was safety testing some sort of imaging device which was worth about 400,000. You don't want to be the one responsible for blowing up a 400,000 pound machine.
Stephen came to the hospital 20 years ago, fresh from university with a degree in medical electronics.
It's nice to see your engineering, your skills and your knowledge of technology is able to be put directly into looking after patients.
Finally, the anaesthetic machine is serviced and ready to test.
This is our test lung, so this is our pretend patient, and we attach it to the end of the tubing, and I'm just about to run the anaesthetic machine as if it was connected to a patient. It's quite a satisfying feeling to fix a machine and get it back up and running again. But this hospital isn't just a place of work for me. My daughter was actually born here. My wife had to have a cesarean, so I've actually witnessed the equipment in use from a different side of the barrier. I don't directly think of us as lifesavers, but our actions do contribute towards patients having their life saved.
You can make the cut from the top, yeah.
In Theatre 13, a team of 4 surgeons are 2 hours into removing Mick's eye and tumour and rebuilding his face.
You have to come anterior from there.
After removing bone in his forehead, the thin membrane covering his brain was torn.
There is a leak of fluid, then you can get meningitis, but the infection collects under the brain, then you can get brain abscesses.
But they can't repair it until Etu first cuts away the cancerous bone in the roof of the socket.
My job here is to separate the dura and the brain. And the reason we're taking the roof of the orbit is because the tumor was one going through the frontal sinus as well as close to the roof of the orbit. Tooth forceps, please.
With the roof of the orbit gone, all of Mick's cancer is out of his skull.
Orbital roof. Specimen here.
But there's still a risk of infections like meningitis entering through the dural tears, so the membrane must be repaired.
I couldn't stop it happening on the roof of the orbit. That's what I'm trying to close it immediately to maintain the integrity of the dural compartment. Okay?
Along with stitches, Matad must reinforce the dura.
Dura is very thin here. So if I can put additional dural barrier there, that would be nice.
First, a mesh with clotting properties is placed over the dura to help stop bleeding.
A little bit of oozing from the frontal sinus itself.
Just because of the anticoagulation.
To further strengthen the repair, Matad will use tissue and fascia from Mick's thigh.
5x5 or 3x3?
2x2. You come through this. So we'll just give Matta this piece of fascia lata to use as a dural patch.
Now we can use it to support our suture line.
So the fascia lata acts a bit like a sort of sticking plaster or band-aid to cover and fix the hole.
Finally, the layers of stitches, mesh and tissue are glued in place. Working on Mick's leg, Sanjay and Nigel are ready to divide the flap of skin and tissue they're harvesting to rebuild Mick's face.
We have to split it straight down the middle then.
One section will fill Mick's eye cavity and one will cover it.
Can you double check my line? I think it's this one. This line, yeah?
Yeah.
All right, fine.
Another one, please.
Just over 5 hours after the operation began,
Yeah.
Sanjay and Nigel can cut the artery and vein to release the flap.
Flap off.
Now they're working against the clock. They must connect the flap to blood vessels in Mick's neck before it dies.
Ideally, I wouldn't want the flap to be off for longer than 90 minutes. If the tissue in the flap starts to deteriorate, if the blood's not flowing around, it becomes unusable. And debate keys, thanks.
An artery and a vein have been exposed in Mick's neck, ready for the flap to be connected.
So we're just going to feed all these vessels through.
Sanjay needs the flap's blood vessels to have some slack in case there's a problem with the new connection.
If your plumbing doesn't go well, you'd have to cut the vessels back, and then they might just end up a bit too short.
No twist.
The vessels are only just long enough, which does put a bit of extra pressure on making sure that our plumbing goes well first time.
Because each vessel is less than 4 millimeters wide, the intricate connection can't be done by the naked eye.
Scope in, lights away.
The surgical microscope can magnify the vessels up to 40 times.
Are we okay here?
First, they work on connecting the two delicate vein ends.
Is that flat then? No rotation on this? Have you clicked it on?
Because veins are thin and pliable,
I love the coupler. Makes life so good, doesn't it?
they use a microvascular coupling tool to join them.
Happy?
Yeah. So the veins can fold the edges over the pins. Really thick.
It's really thick, isn't it?
Yeah.
Like a sea anemone.
And they sort of interlock.
Okay, click please. That's
good. Thank you.
They have 46 minutes to finish plumbing in the flap. But artery walls are thicker and need to be carefully sewn by hand.
not too much table, Wobbly.
Guys, sorry. We're on it now, so... Any movements makes it impossible to stitch.
About 3 or 4 more stitches. Clamps are coming off. You'll see the anastomosis run, probably.
It's taken 1 hour and 14 minutes to connect the flap to Mick's blood supply.
That's good, not much bleeding.
Scope coming out.
The real test is to see whether the flap is getting fresh blood.
So let's just check the flap's bleeding.
We always fear the blood not flowing properly and keeping that tissue alive. If it doesn't stay alive, he's then committed to having further surgery to keep him safe.
Bleeding's good.
This bleeding's good, yeah.
And it's bleeding the right colour.
But just as the surgeons are about to close the flap, there's bleeding they don't want.
Etty's still a bit from that orbital apex.
Blood is building up at the back of the eye cavity, but they can't tell where it's coming from.
It's really important that we stop the bleeding there, because that will just go to the easiest space for it to go, which is going to be backwards in the cranial cavity and cause a stroke or even death. Yeah, it's coming from here, but this is still...
It's coming from above that, Sanj. coming from my subs. Can I have a syringe and so on? Yeah, that's
Oh, there it
that
is.
Yeah, that's
Okay, bone wax. What have you got? Little bony thing.
The bleeding is coming from a vessel within the bone. So these can be a bit sneaky because you can't really see the vessel.
Hetty, do you want us to put a layer of Surgicel and then flow seal, or just go straight to flow seal?
Put flow seal and put some Surgicel on top of it.
No, but no.
We can't insert the flap until all of that bleeding is sorted out.
Flow seal.
They add a clotting agent.
Surgicels.
And a highly absorbent gauze that stems the bleeding. After packing the wound,
It's pretty dry now, I think, isn't it?
they can continue rebuilding Mick's face.
So we're just taking the skin off.
One half of the flap fills the eye socket.
Or should we drop it into the plate will sit nicely now. Yeah, I don't think it'll be a problem.
Then a hard metal mesh, moulded to the cavity, is permanently secured to maintain the shape of Mick's skull and protect his dura, as well as the bone he has lost. It's made of titanium because it is well tolerated by the body.
Just on the outside of that line.
Next, the other half of the flap
Blade, please.
covers the socket.
We're just closing now.
We need to get the reconstruction to be as good as it can possibly be, because that's what they're going to see every morning when they look in the mirror.
It's taken 5 surgeons, more than 8.5 hours, to remove Mick's cancer and rebuild his face.
Sounds like Michelangelo. Can you just cut that short then? I thought you were okay. I had to carry you for quite a bit of the operation. You know, swings and roundabouts. I might have an off day too one day.
Mick's leg has been stitched and will heal in 10 days.
Mick, operation is finished. Take some nice deep breaths in and out. Deep breaths in and out.
Mick will spend the next 24 hours in intensive care, under close observation.
We won't know whether we have truly got all of the cancer out until we get the final histopathology.
It's 5:45 in the evening and everything's gone really well. Thank you very much, everyone.
We'll start the operation in a minute.
In Theatre F, Vicky and Julian are still struggling to remove Norman's cancerous bladder and prostate.
Oh, hello.
Have you got an in?
We've got an in, yeah. We're feeling there.
They've managed to detach the large walnut-sized bladder from many of the ligaments that hold it in place. But the front of the bladder is welded to Norman's pubis bone by scar tissue from his previous radiotherapy. It's so stuck, cutting it away is too high risk.
We don't want to force it with scissors. If we puncture the bladder, then we could have a tumour spill, and that would result in cancer around the abdomen.
Oh, the contour.
The only option they have to try to free the bladder without tearing it is to use one of the oldest surgical techniques, blunt dissection, separating tissue with their fingers.
She feels like you can almost sweep up to the pubis there.
Yeah, well, I think you just got that tissue there.
Doing all of this relatively blind, you're just reliant on your touch.
Is that pubis? There you go, you can feel the pubis there.
Yeah.
There's a little bony spur.
Yeah.
And that's going to help.
You're pushing against the bone to try and dissect the bladder away from it.
It is coming with blunt dissection.
And that is safer than trying to rip the bladder off it.
Okay, I think I'm into the fat beneath it.
Nice.
It actually feels like trying to peel solid chewed chewing gum off the underside of a table, but just with the end of your finger.
Have a feel, see how...
Oh yeah, loads. That's nice.
Julian works on the bladder from his side of the table.
So I'm just right on the pubis, all the pressure is going onto his bone.
Yeah.
Hopefully, millimetre by millimetre, we're getting peel of the bladder off the bone. There you go.
Happy days.
Finally, the bladder is free from Norman's pubis bone.
Okay, look, I mean, we could probably stop there.
Now, Julian must use the same technique to try to separate Norman's prostate and rectum that are also fused together.
Feels really stuck to his pelvic floor, and his prostate now is coming into our fingers and feels hard.
If he rips the rectum, it will be too damaged to repair. That would leave Norman needing a stoma for solid waste, as well as one for urine.
I think it's going to be pretty sticky posteriorly. You'd be delighted to hear. The greatest challenge is that the plane is about 1 millimetre wide. My worry is, if I don't stay on the right side of the millimetre, I'll be in his rectum with my finger. We'll be able to smell faeces, and he'll need a colostomy bag. Little by little, recheck, little by little, recheck. Where's the danger? On the right side, I mean. If I rush it, I could tear the rectum. So I'm just going to go steady. Okay, well, look, I managed to slide down his prostate.
Oh, that's good. Nice. That is really quite nice, isn't it?
4.5 hours after Norman arrived in theatre.
So you got your finger keeping the rectum safe?
It's just a tiny bit. Can you see that there?
No. Oh, yeah.
Put that tissue there.
Vicky can finally take out Norman's cancerous bladder and prostate.
Yeah, take it. There you go. Right.
Special.
It's quite a relief to get the specimen out now. There's been no giveaways, there's been no easy steps, so we've had to work really for every moment of this operation.
Feels like a palpable achievement.
There is one more vital task for Vicky and Julian. Now Norman has no bladder. They must construct a way for him to pass urine through an opening in his abdomen, called a stoma.
Leahy?
The one thing that Norman's going to have to live with for the rest of his life is with stoma.
Make sure you stay safe here.
Yeah. It's really important to make sure you do it as good a job as you possibly can.
I think it's going to look good.
To create the stoma, they cut out a section of Norman's small bowel.
Okay, so that looks like a decent pipe for us, doesn't it?
And connect it to the pipes that carry urine from the kidneys, so urine can be expelled.
Stick those up there.
Through an opening in his stomach. With a bag connected to his stoma, Norman should no longer be up 23 times a night to urinate.
Well, this guy's going to have his first good night's sleep.
Yeah.
In a long time.
Norman's bladder and prostate will be sent to the hospital's pathology lab.
The pathology will tell us how extensive the tumour was, whether or not we've got all of the cancer out, and therefore whether or not we've cured him.
Surgery is all finished. It's gone very well. We're just giving you a bit of oxygen to help you wake up. You're very safe.
Norman, I'm just going to put your hand under the blankets to warm you up. You're a bit chilly.
Norman will spend one night in the high dependency unit.
Thank you.
If all goes well, he'll go home in 5 days. It's been 2 months since Mick had his eye removed, and he's visiting his sister.
With my eye, I can see the spoon, but you can focus in on things. Let's say I pick that up, and to really concentrate on picking that up. When I woke up and I opened my eye, I could see lights. But it slowly dawns on you, from now on you'll have one eye. Right, OK. So you start to come to terms with that.
His skin flap is healing well and will ultimately blend in more naturally.
I think the patch is some of the neatest bit of needlework I've seen in a long time. The stitching is immaculate. Clever, very clever surgeons.
In addition, the pathology results show Mick's now cancer-free.
You have had your money's worth from the National Health.
Well, I have. Cool. 10 times over. I can't thank the surgeons enough for the job they did. They're geniuses, what they do.
We're all really pleased about that shared decision that we made to go ahead with the surgery. It's amazing to be able to be part of a process to cure somebody from a serious illness or disease, and I'm just really thankful for the team I work with. You can't do this alone.
Two and a half months after his surgery, Norman is embracing life.
I can feel my strength coming back. So today I am feeling really good.
Oh, hi, darling. Did you get everything we need?
Yes.
He can do much more. He's got more energy. It's kind of like getting my husband back again. Hi, hi. Lovely to see you.
With his new stoma bag, Norman is no longer waking up throughout the night.
Looks like you made an astonishing recovery.
Yeah, thank you. I feel extremely well. The biggest change in my life is I sleep through the night, and I rejoice in that. I have up days and down days, but lately it's been mainly up, hasn't it?
We're just living normal lives again, which is great. There we go.
Tests show the surgeons successfully removed all of Norman's cancer. He now hopes to start cycling and to go on holiday with Miranda.
The future now is looking extremely rosy. We could have a jolly good 20 years ahead now.
I look forward to however much time we're given.
Oh, dear, dear.
It's a blessing and a bonus, and we'll make the most of it. So it's been a long old haul, and you are very much better.
So Norman wrote me a thank you letter, which was just really lovely to receive. It's so nice to hear how patients are doing, to know that his life is better for it.
Cheers. Well done. Well done.
To hear that that has been successful is immensely satisfying.
Next time,
Don't let me down.
2 life-changing operations.
Tough bone.
Push the boundaries of surgery.
You could have catastrophic bleeding.
Quite a lot of blood.
And precision is the difference between success and failure.
If you're too gung-ho, you could crack the bone.